In less than half a second, in the time it takes a camera to capture an image, you capture the most important moments of your life. In less than half a second, as fast as an eye blink, you could capture the most important moments of your patient's eye health. In less than half a second, you can get the whole picture. The OptiMap technology images the retina faster and with a wider field of view than ever. OptiMap technology produces images that reveal more pathology, helping you find disease sooner and treat it more effectively. Less than half a second can help you prevent vision loss in your patients, so those important moments never fade from view. Less than half a second, and this proven tool helps you uncover critical information to make more effective clinical decisions, as shown in over 400 peer-reviewed studies. Less than half a second, and you will see the value of OptiMap imaging and diagnosis, treatment planning, and patient engagement. Less than half a second can increase your practice economics. Faster retinal imaging frees you to do more patient-critical activity. The most important moments of your life can be captured in less than half a second. That includes an OptiMap image.
Hi, good evening, everyone. Welcome to this evening's webinar on the benefits of Optos ultra-wide-field retinal imaging for private eye clinics. My name is Dr. Pei Kek Ki, and I'll be moderating tonight's proceedings. On the panel also, we have Dr. Jacob Cheng, who is a consultant vitreoretinal surgeon at Eagle Eye Center in Singapore. He is an experienced clinician who is also an adjunct research scientist with the Singapore Eye Research Institute, clinical teacher with the National University of Singapore, and part-time consultant at the Singapore National Eye Center. He is actively involved in research projects in collaboration with many international institutions and has published many peer-reviewed scientific papers. We also have Associate Professor Yotpong Chantarasorn, who is the head of medical retina at Vajira Hospital, Thailand. Dr. Yotpong holds a research fellowship in vitreoretinal disease from Mass Eye and Ear Infirmary at Harvard Medical School and certificate in applied biostatistics from Harvard Catalyst. Tonight's format will involve 3 pre-recorded videos. I will show evidence as to why I think the Optos is a fantastic camera. Dr. Jacob will show real-world examples, and Dr. Yotpong will bring everything together. After each talk, we'll have a 3-minute break to answer any questions the audience may have, and also for panel discussion. Before I begin, I would like to thank Nikon for hosting this webinar, as well as the Association of Malaysian Optometrists for the support. So without further ado, let us start with my pre-recorded presentation.
Evening, everyone. My name is Dr. Pei Kek Ki, and I would like to thank Nikon for inviting me to speak regarding a modality that has changed my practice and to my mind is indispensable as part of modern ophthalmic practice. A little background about myself, put into context how Optos ultra-wide-field imaging fits into my practice. My subspecialty interest is in the field of vitreoretinal disease. Following subspecialty training in the southwest of England rotation, I had completed a medical retina clinical fellowship in Birmingham before embarking upon surgical fellowships at the Royal Perth Hospital, Western Australia, and the John Radcliffe Hospital in Oxford, United Kingdom. I worked in Singapore for 4.5 years prior to commencing at Sunway Eye Center in 2020. Sunway Eye Center is an 11 consultant practice with 3 additional visiting consultants located within Sunway Medical Center. Sunway Medical Center is a 616-bed private hospital, which by the end of 2023 will grow to 1,100 beds. So we are a fairly busy tertiary referral center with all subspecialties represented. The Optos camera has been with us since 2013. We were the first practice in Malaysia to have one. In fact, when looking at practices to join in 2019, this was the first piece of clinical equipment I had asked about. Our Optos Daytona is located within our imaging suite, comprising another ultra-wide-field camera from Zeiss, in addition to our Zeiss Cirrus 700 OCT and OptoView OCT machine. We have 7 trained optometrists who operate the Optos Daytona. Images are accessed via the Optos Viewer software, which is available desktop terminals in all the consultation suites. Patients usually come from 2 sources. Firstly, our team of 4 endocrinologists who offer diabetic retinopathy screening to all their patients. Secondly, internally from within the eye center, which includes my VR colleague, Selva. Personally, I request for ultra-wide-field imaging for all my patients as I'm so convinced of its value as a diagnostic tool. Clinical studies have shown its effectiveness as an adjunct in aiding diagnosis. Skeptics will bemoan the loss of fundoscopy skills, the lost art of slit lamp biomicroscopy, etc., etc. In response, I will point out that Roger Federer played tennis with a modern graphite racket, not a wooden one like Bjorn Borg. So why should I not use an effective modern tool for my sport? Continuing this metaphor, Bjorn Borg won all his 11 Grand Slam titles using a wooden racket prior to retiring in 1981. He tried to come back in 1991, still using the same wooden racket, but was woefully outclassed. So why not move with the times and win with Optos ultra-widefield imaging? In my practice, all patients have their visual acuity and IOPs checked by the nurse and their pupils dilated prior to undergoing ultra-widefield imaging. I then view the images on the Optos viewer and take note as to the areas of further interest. Additionally, the viewer enables image manipulation of exposure, contrast, and gamma settings, which can highlight pathology. This reduces time examining the fundus on the slit lamp, which makes it more comfortable for the patient. For example, in assessing diabetic eyes, a wide field view improves classification of diabetic eye disease. This picture of a patient we photographed shows how a potentially serious diabetic eye disease could have been missed if a standard 50-degree fundus camera had been used to screen. According to a Joslin Diabetes Center study, this happens in 1/3 of patients. The ability to manipulate the magnification of the image, its parameters, often can highlight details that would just not have been possible without significant time shining the slit lamp beam into the patient's eyes. In this case, this could mean the difference between diagnosing someone as moderate non-proliferative diabetic retinopathy versus severe non-proliferative diabetic retinopathy. To me, ultra-widefield imaging is crucial towards helping patients understand their disease. Furthermore, this frees up chair time for consultation. Often, one can make a diagnosis and formulate a plan prior to actually calling the patient in. After all, a picture speaks 1,000 words. In the setting of a retinal detachment, it is often that I find it really useful showing patients a picture of their retinal detachment as an aid to understanding the condition. Occasionally, it is helpful to remind patients of their pre-operative macular status in the event they query as to why their vision post-recovery is suboptimal. For those who do pediatrics, this is an example of how I use ultra-widefield imaging in retinopathy of prematurity screening. Using the Optos this way made examining the infant much less traumatic and arguably more effective in staging disease. Another utility of ultra-wide field imaging is in population screening for diabetic retinopathy. This was a study I'd done whilst working in Singapore, which compared the utility of an Optos Daytona ultra-wide field imaging camera versus a standard 50-degree fundus camera. An initial observation was that we managed to obtain gradable images in 100% of patients. This is due to the fact that the Optos uses a scanning laser to obtain its images as opposed to the flash images captured using a standard fundus camera. Image acquisition time was faster, and patients preferred having the examination done using the Optos camera. To me, however, the key finding was that the Optos was more accurate at staging diabetic retinal disease. 13% of patients had their retinopathy staging upgraded to moderate as opposed to normal. 2% were upgraded to severe diabetic retinopathy and had PRP laser recommended to reduce the risk of severe vision loss. This was proof of concept that, at least in the context of diabetic eye screening, the ultra-widefield imaging improves classification of diabetic eye disease, which leads to early detection of preventable vision loss. In summary, it is a winning tool which provides faster image acquisition, which is more comfortable for the patient, better and arguably more accurate diagnostic sensitivity, which potentially saves vision, and is cheaper because vitrectomies are way more expensive than PRP laser. Thank you very much for your attention.
So that was my short introduction to what convinced me as to the utility of the camera in clinical practice very early on. In fact, I often tell this anecdote that as far back as 2012, when we first got a camera in the Royal Perth Hospital, we were trying it out on all the staff, and we picked up 2 members of staff who had asymptomatic retinal tears in the periphery. Are there any questions from anyone, or we can open the floor to questions, and any questions or discussion points from my fellow panelists?
Thanks very much for sharing, Dr. Pei, on your journey with the Optos, actually. I also heard very much about doing the screening of RP using the Optos, and I think it's really very useful. Do you face any challenges using the Optos, or do you do yourself, or your pediatric ophthalmologist does the screening on the Optos for pediatric patients? Just wondering. It's not easy, right? The flying baby position, actually. Yeah.
Yes, it was a challenge. The biggest challenge was the fact that the pediatric unit was located about 800 meters away and 2 floors away. So I still remember every Monday morning, myself and we had a dedicated medical photographer. We wake up at 7 o'clock in the morning, and we go cart our Optos California. That was one of the first California models, was mounted on a specially made rig, and we just wheeled the entire machine over to the pediatric ICU, the neonatal unit, and we did the screening. So to me, that was the biggest logistic hurdle, was getting the machine over there. But in the 1.5 years that we were doing ROP screening, we managed to have no interruption. So that speaks to how sturdy the machine was. There's a question from the panel. Is there any effect from the laser if the eyes are often shot into the Optos machine. As far as I know, no, because it's and in fact, I think it's much more comfortable. It's a scanning laser, so it's not a thermal laser as such. So as far as I'm aware, there is no lasting damage to the retinal tissue.
I would also like to ask a question that do you still do pupil dilating exam for DR screening, or those with stable DR that has been treated adequately treated?
Yes, I do, because I find that in my clinic, the workflow works better if I pre-dilate the patient. Also, because most of my patients have VR pathology, there are certain things that we want to look at in the periphery that would just not be possible if we did not dilate. So although for stable screening, yes, routine screening, we do not dilate. But if these were new patients, I would dilate them.
Okay, thank you.
There's another question. When you see peripheral holes in asymptomatic healthy patient, what is your guideline for treatment? Well, in those cases, I think there's clear evidence that treating asymptomatic holes don't prevent the retinal detachment. But to be honest, sometimes you can always talk yourself in doing laser, and you have to have a frank discussion with the patient as to the risks versus benefits, and decide, whether the patient, I think mostly it's patient guided. Some people are very worried, that they have a hole in the retina. So yeah, so shall we move on, and if we listen to Dr. Jacobs' presentation on real world cases. If you could play Dr. Jacobs' presentation.
Hello, hi everyone. Good evening. Welcome to this evening's live webinar, Benefits of Optos Ultra-Widefield Retina Imaging in Private Eye Clinic. I want to thank Nikon and Optos for putting all this together. This evening, I'll be sharing on the clinical value of ultra-widefield imaging, and these are my financial disclosure. And other than showing the color cases and in demonstrating the clinical value of Optos ultra-widefield imaging in eagle eye center screening services, I also want to share a little bit on the autofluorescence function, the fluorescein angiography, as well as indocyanine green angiography. These are some of the cameras I had the privilege to try out thanks to the collaboration with the various companies. We are also very familiar with the imaging capabilities of the Optos ultra-widefield 200 degrees fundus imaging capabilities, but on board California, we also have the fluorescein angiography, the autofluorescence, as well as the indocyanine green angiography, which I'll talk about shortly. The term ultra-widefield has yet to be accurately defined, but is gaining popularity after introducing images with more than 150 field of view. We are also very familiar with the retina images by the 30 degrees 7 standard subfield, 35 mm stereoscopic colors from the EDDRS study. And in this picture, we also have the Optos 100, older version of Optos. In the background, we have the Optos 200, where it's been shown that this ultra-widefield image shows up to 3 times retina areas more compared to the 7 subfield EDDRS, and even up to 20 times that compared to a normal color fundus photograph. We do know that pathologies lurking in the periphery, be it medical or surgical, and many of these are evident on the retina but long before the patient notices any symptoms. These usually go undetected using traditional examination techniques. So important with the ultra-widefield to allow for additional diagnostic information to provide this prompt, timely guided treatment, especially important through a 2.2 millimeter pupil. Actually, another title of my talk is actually seeing more. What can we actually see more than we actually have already seen on the ultra-widefield? We are all familiar with a normal fundus photograph, but actually when we superimpose it on a background of a 200 degrees ultra-widefield, is actually quite small, as you can see within the red box. Here in this patient with a cinematic left eye with floaters, he actually has a superior nasal retinal tear in the far periphery, as you can see in the red circle. He declined or wanted to defer treatment until a week later, where he was actually more cinematic with a peripheral scotoma. Here you can see that laser retinopexy was applied not just over the retinal hole or tear, but also beyond that, because there was very retinal fluid accumulation. A week later, he came back, and of course this time he was more cinematic because you can see more subretinal fluid, and then he has developed a retinal attachment for which he had to undergo a surgical intervention for this. So it's very important in this day or age to really document the progression from simple retinal hole to retinal detachment with sequential ultra-wide-field photograph, and also important to really document on the opposite eye where it's acinematic with this lattice degeneration which predisposes him to the similar pathology as he has on the cinematic left eye. What do I mean by seeing forest through the trees? Here you can see a patient who presented with a diabetic retinopathy screening 2 years ago. Here you can see the patient actually has at least a severe diabetic retinopathy in the right eye. You can see evidence of dot blot hemorrhages and cotton wool spot even in the far temporal periphery of the right eye. Here a zoom in view where you actually don't lose resolution. You can see florid signs of the dot blot hemorrhages as well as the cotton wool spots. Patient came back this time around, and it seems that retinopathy seems to have either resolved or actually at least reduced in this eye. But actually he came in with the symptomatic left eye comparing floaters, and here you can see vitreous hemorrhage. Compared to the photograph that was done 2 years ago, you can see patients actually that time he actually had quite a bit of retinopathy, again with the cotton wool spots as well as dot blot hemorrhages in all 4 quadrants. Does it mean that this time round he actually has better diabetic retinal control? But he actually came in cinematic this time, and actually his HbA1c was actually higher than compared to 2 years ago. Here, going back into the original right eye, it seems that the retinopathy has sort of resolved or at least reduced, but we zoom in on the details, where you can see within the red circle, a close-up view where you can actually see a retinal front of a neovascularization, which you do not see previously. Here, a zoom-in view, a close-up view, you can see quite clearly the neovascular elsewhere, NVE, as within the red circle. Compared with the photograph 2 years ago, where he actually had a lot of dot blot hemorrhages, but no neovascularization or NVE then. So it's important not just to see the big picture, the forest picture, but also zoom in on the views of the trees and getting details and not losing resolution. What do I mean by seeing beyond the colors? Here, we don't just want to see the color image of this choroidal nevus, but also with the green and red separation, with the green channels of green laser, which is actually showcase the sensory retinal RP better, as you can see in the top right channel or picture, where we can demarcated by the red arrows, and the bottom right where you can see with the red separation or red laser, where the RP and the choroidal structures will be more evident. I can see the choroidal structure better in this case. So in this case, where you can see the laser scars in this patient with proliferative diabetic retinopathy, as well as even the anterior structure, like the vitreous hemorrhage, as you can see here inferiorly within the red circles, are seen quite nicely. And using the green channels where it highlights the retina as well as the anterior vitreous structure better, you can see. And again, the zoom-in view, seeing not just the forest but also the trees, where you can see the reason for the vitreous hemorrhage, where you can see the NVEs and NVDs here. And using the green channels where highlighted with the red arrows, where you can see it better. What do I mean by seeing beyond the still? So here we can actually showcase again the peripheral laser scars in this patient, as well as the anterior structures better, like the vitreous hemorrhage. Enhance using the green channels. So using the Optos, we actually can have a very nice video, 200 degrees stereoscopic field of view of the retina, and also useful for surgical intervention and not just to be able to appreciate the pathology better. What do I mean by seeing beyond the request or the complaint? This young lady came in with complaints of blurring of vision, requesting for LASIK or refractive procedure done, but you can see on this Optos-Widefield, don't really see much pathology. So in this magnified view, where you can actually see flame hemorrhages as well as silver wiring, over the disc you can actually see disc margin blurring, as well as cotton wool spots. Here you have a patient with a superior temporal branch retinal vein occlusion, and a close-up view where you can see the laser as well as sclerosed vessels better. And again, the green channels where they highlight the pathology clearer. So it's important to document and examine the acinematic opposite eye beyond the complaint of the cinematic left eye. Here, with a magnified view, we can see a sclerosed vessel inferiorly in this acinematic right eye with a wedge-shaped discoloration. As you can see within the red circle. And using the green channel, when I enhance the sclerosed vessels and wedge-shaped discoloration, you can see it's from the ischemia, damage from non-perfusion of this inferior retinal branch vein occlusion on the opposite acinematic right eye. What do I mean by seeing beyond the obvious? So obviously in this patient you can see very highly refractive cholesterol crystals, in this case of syncytial scintillans in the vitreous cavity. We have a magnified view of the posterior pole where you can see another form of highly refractive crystals, but this time this here is over the macula or fovea, as you can point it out by the red arrows. And again, a magnified view where you can see these are actually not the syncytial scintillans, obviously, but again, these are drusen over the fovea. And again, highlighted by the autofluorescence, which I'll talk about shortly. So what do I mean by seeing beyond the black and white? Here in this color fundus where you can see white and yellow fundus spots which are not drusen with atrophic macular degeneration and even from scar. Here we have the diagnosis of Salisbury pseudoinflammatory macular dystrophy. We do know that this pathology involves the atrophy of all three layers, the retinal pigment epithelium as well as choroid, starting centrally, progressing towards the periphery, and it is green channels where they highlight the retinal and RP pathology better. Here, using the red channels where you can see the atrophy of the choroid starting centrally and slowly progressing to the periphery. Here, beyond the black and whites, we can actually see using the autofluorescence highlighting the destruction of the RP layer better, which we do not see on the color fundus photograph. Here in the opposite eye of this patient with Salisbury, where you know it's a bilateral disease, pointed out by the arrows where you can see areas of hemorrhages as well on this color fundus photograph. And the hemorrhages seen highlighted as darkened spots on the green channels. Here with sequential Optos photograph, we can see that the hemorrhages has resolved, pointed out by the red arrows. And again, destruction of the retinal pigment layer where you don't see on the color fundus photograph, where you can see on this autofluorescence the hypo and hyper autofluorescence spots. Again, a magnified view of the autofluorescence photo images. And again, you do not see those destructions of the RP layer on the color fundus photograph. So in this patient with retinal dystrophy, we can see very fluid chororetinal atrophy in the periphery. And using the green channels to highlight the retinal atrophy, and the red channels to showcase the thinning of the choroidal pathology, but you can see the sparing of the fovea and macular area. This other patient doesn't seem to have a stormy or seem to have not as bad a peripheral pathology, retinal pathology of bony speckle pigmentation and peripheral pathology like the earlier patient. But on the green channel, you can see that they also not much of retinal pathology like the earlier patient. By using the red channel to highlight the choroidal thinning and atrophy, which involves the central macula. So this patient actually can see on the color fundus growth photograph and green channels where you don't see much retinal pathology, but red channel highlighting and showcasing patient actually has worse choroidal pathology. This patient actually presented with worse vision compared to the earlier patient. What do I mean by seeing the routine? Well, skeptics and critics of the ultra-wide field or the Optos system saying that colors are actually not true and refractive of what they actually see of medical retinal cases. Here you can see a ultra-wide field view of this patient's right eye. Magnified view looking at the trees and not the forests and details. You can see opacification of the retina, parafoveal gray sheen, as well as RP hyperpigmentation, crystalline deposits, giving the diagnosis of parafoveal telangiectasia in this patient. On the red channel, you can see that the crystals are not highlighted on the red channels, meaning that it's not a choroidal or deep pathology. But the green channels, where you can see there is a retinal pathology where the crystals are actually seen better. So another routine case of central serous chororetinopathy, or CSR or CSCR for short, using the green channels where you don't see much pathology on the retinal surface. By using the red channels where they highlight the choroidal vascularity or the increased vascular perfusion better. But here, using the autofluorescence features, we can see the hyper and hypofluorescence of this patient's right eye with the CSR better. Again, it's useful to perform a ultra-wide field of this patient's CSR using this fluorescein angiogram. The ink blot appearing as well as RP changes. And it's important to document on the opposite eye because we do know that CSR can be bilateral, and here you can see in the asymmetric left eye, patient also has an ink blot appearance. So we have seen some routine cases. How about seeing beyond the routine? So this can be a routine ultra-wide field photo of this patient with RP where peripheral bony specular pigmentation, pale disc, and tenured vessels. But if we look in the periphery with the ultra-wide field, you can see a dislocated IL, of course, with patient with a weak zonules. What do I mean by seeing the flow or seeing beyond the flow? We do know that in patients with, for example, like central retinal vein occlusion with peripheral capillary non-perfusion, it's important to document the non-perfusion other than looking at the central macular leakage. And again, it's very important and it's very laborious and tedious. And you really need a good technician to really have the 9 photographs on each eye to be able to document the pathology well. Here in this patient with a branch retinal vein occlusion of the left eye, important to use a ultra-wide field to document the extent of the pathology, not just looking at the central foveal macula looking for edema, but also the peripheral fallout and ischemia with the flame hemorrhages. Here, a magnified view of the patients where you can see the flame hemorrhages as well as sclerosed vessel better. So useful with a ultra-wide field, fluorescein angiogram, where you can see delayed venous return, peripheral fallout and ischemia, as well as a delayed vascular perfusion. And a late phase where you can see vascular damage. Zooming in into the central fovea or macula, we can actually see the macular ischemia better. And again, it's important with the ultra-wide field to document the opposite eye, even though it's asymmetric. Here you can look at the peripheral of the opposite eye, where you can see here hyperfluorescence in the superior and temporal aspect of the asymmetric eye, which can easily miss, and again, you do not see this on a color ultra-wide field photograph. So again, showcasing the importance of the ultra-wide field on angiography in vascular cases. How about in arterial occlusion? Here you can see a normal fundus photograph with the whitening, swelling, and edema of the superior retina with limited view. So here with the ultra-wide field, you can see that it's not just a superior temporal pathology, but almost the entire hemifield superior is actually involved. And we do know the anterior occlusion is an intracellular edema swelling rather than just extracellular, resulting in this clinical grayish-white retinal opacification. So useful again with the help of an ultra-wide field fluorescein angiogram to look at the delayed arm retinal time. So magnified ultra-wide field view of the retina showing delay of the arterial perfusion. And you can see that over the fovea is not really involved as the patient has reasonable vision except for inferior field defects. So in this another routine typical case of CSR, where you can see there is a pigmented tract temporal to the fovea. And using the green channels where it's not very obvious. And using the red channels where you can see the dilated choroidal vessels, where we do know in CSR you have this increase of choroidal vascularity. But here you can see on the autofluorescence where you can see the tract better evidenced by the hyper and hypo autofluorescence due to changes of the RP layer. With the fluorescent angiogram, you can see the staining on the track as well as the ink blots coming up. And with this ultra-wide field ICG, you can demonstrate the dilated choroidal vessels better, not just centrally, but also in the periphery. And again, demonstrating that this can be a bilateral disease on this patient with CSR, where we demonstrate the ink blot on the opposite asymptomatic eye. And again, the dilated choroidal vessels here on the ICG wide field. So I just want to thank all of you for your attention and have a wonderful evening.
Thank you, Dr. Jacob, for that amazing presentation. As always, I'm astounded by the breadth and of cases that you have and documented on the Optos wide field, and I think it's a fantastic, it just underlines how important it is to be able to manipulate the images, as I alluded to, using the green channel, the red channels, to highlight pathology. And also, it was a great summary and gives deeper understanding of the diseases that we are seeing and in following them through. So once again, let's open it up to the audience for any questions. And there's a question to Dr. Jacob. Have you captured stereo images on the Optos? And how do you view it on the Optos? Are you able to view the stereo images without 3D glasses? Dr. Jacob, would you be able to answer this question?
Earlier, I shown that there's actually a video function actually that we can actually capture, but somehow on my screen, it didn't show the video very well. As for stereo image of the Optos, I really haven't used that before actually, so I must admit that I'm sorry, I'm not very familiar with that actually. Yeah.
Yeah, I don't know, if in these days of, image separation and segmentation, whether or not having a stereo view is as important as it used to be. I remember the old days where we had these handheld stereo viewers, and we were constantly adjusting the IPDs, to view stereo fluorescein angiograms, to determine at what level the leakage was, But these days, I think with OCT segmentation in conjunction with 2D image manipulation, I think you can obtain the same amount of detail. Thank you for the question. That was that's a great question, actually. Yeah. And now, finally, we move on to Dr. Yot Pong's presentation. And if we could play Dr. Yot Pong's presentation, that would be great. Thank you.
Good evening, everybody. I'd like to thank Nikon for this opportunity, and today I'm going to be talking how we can incorporate Optos into the concepts of retinal workflow in practice. Let's get started. First, let's take a look at a definition and importance of an efficient workflow, which is really the process that is lean in terms of time and space, still provide complete and well-organized data that is handy and readily available on the same screen. Several benefits of an efficient workflow include organized data that allows better comprehension of each patient's disease status so that we can individualize treatment and avoid ordering redundant labs and procedures. Secondly, lean process help us maximize uses of limited space in the clinic. And lastly, we can examine more patients in the same amount of time, or we can have the same amount of patients but can get off the clinic earlier. Also, reduction of waiting time may translate to some better clinical results. Which leads us to the next topic about an impact of workflow on real-world outcomes and follow-up adherence. A prior study showed that waiting time for anti-VEGF injections longer than 15 minutes was associated with more anxiety and increased pain score for patients who received injections during the second visits. Let's take a look at 2021 cohort in my clinic where we reviewed 160 naive diabetic patients who visited eye clinic for DR screening. And the data showed that 2/3 of the patients took longer than 6 months from the first diagnosis to receive actual DR screening. And part of the reason was they felt that their vision was still fine, so they didn't want to waste more time. This was based on the fact that we have a fast-track system where patients can come to the eye clinic for DR screening on the same day with their first DM diagnosis. As expected, 14% of those naive cases who were supposed to get eye exams several months back had vision-threatening DR requiring treatment at the presentation. Similar trend has been seen from wet AMD treatment in Thailand where patients can access to free anti-VEGF effortlessly. However, 1/3 of the patients lost their follow-up after year 2 of anti-VEGF therapy, leading to deterioration in final visual acuity. So let's move to the next topic on how we can create a better workflow. And there are 3 pillars to create the efficient workflow. These include time, space, and data. And let me break it down one by one for you. Let's get started with the appointment time where we hire an IT company specializing in healthcare system to analyze the data based on the waiting time in the past 3 years. And the goal is to minimize mean waiting time to less than 30 minutes. The results showed that patients should be categorized into 3 groups, where Group A, or those with simple conditions, and Group B, or cases requiring pre-specified interventions like laser or injection, should get to the clinic at the early time slots. This is because their time spent in the clinic is quite predictable. However, Group C, or those with multiple investigations, particularly who were unsure of the final diagnosis or treatment plan, should get to the clinic later in the day. Finally, we'll have spare time for new patients between each time slot while not compromising the waiting time of the current ones. For example, a diabetic patient who underwent complete PRP in the left and combined phaco-vitrectomy in the right side for tractional foveoschisis presented in the latest follow-up with improved morphology. However, the OCT showed RHEL in the left side and persistent outer retinal layer loss on the right side, both of which were untreatable, so he was sorted into Group A, or the simplest one. Please note that these photos were taken through non-dilated pupil, as we know that most DR pathology tend to locate in posterior pole. Secondly, we need to define the lane or a time slot for each one, and that we try to simplify things by using an easy term like fast or slow lane. For instance, we would designate a slow lane taking around few hours for patients scheduled for screening of chloroquine maculopathy, or those with unknown causes of vitreous hemorrhage requiring B scan and possibly OR schedule. Whereas the fast lane would be selected for some patients with stable AMD or DME that need only a fixed interval injection and OCT on each visit. Here is an AMD fast lane where the patient gets the scans and subtenon anesthesia and was moved directly to the injection room. Big advantage of subtenons is less pain score and shortened time spent on multiple anesthetic eye drops. So sorry that this is in Thai language, but the principle is the patient will scan the barcode on the appointment card, then they'll get their numbers and colors that will tell them where to go. So no matter what the patient's lanes are, each of them will have a color sign to navigate the direction clearly. Finally, we need to build the right foundation, which is proper training to imagers. These include how to utilize software, basic anatomy, and disease pathology so that they can focus on pathology and ignore artifacts. For example, a 25-year-old man was referred to our clinic for excluding hereditary retinal dystrophy due to a history of progressive nyctalopia in both eyes. On presentation, a resident ordered full retinal investigation. However, the imager suspected high stigmatism after noticing large artifact during fundus photo. He then performed corneal topography on the patient, which revealed a classic bow tie pattern of irregular stigmatism. So the diagnosis was changed to keratoconus, and the patient was referred to corneal specialist. Once we get patients come in the right time and go in the right lane through well-trained staff, then we should coordinate the imaging flow by avoiding bottlenecks or unnecessary movement in the flow so that we can remotely review and get the max out of data even before the patient enters the exam station. So let's take a look at electronic medical records, where typing data in EMR is one way to lean a process of data collection, since we can copy and paste the prior history into a same page easily. Let's have a look on the left side, where we rely on the scanned written records that require us to go over one page at a time, as compared to having all the data within a single page that can be pulled up simultaneously. The analogy is like comparing driving by looking at the milepost versus using GPS. You can see that these two different brands of EMR use the same principle of history consolidation that can be quite beneficial, especially when patients have multiple visits or different clinics, since we can go through such a long history in a short amount of time. Then we'll examine the patients, walk them through their images to help them understand their disease status, and discuss the treatment plan. The decision to either accept or decline the treatment is faster when the patient comprehends their disease through photos. For instance, this 52-year-old woman with a long-standing history of diabetic came to us for conjunctivitis. She's been visually asymptomatic with 20/20 vision and never received DR screening. Her A1C has been well controlled. So there are a significant number of Thai patients who believe that eye complications will never ever happen if their sugar levels are well controlled, so they end up never coming for DR screening. And on the follow-up date, we performed Optos and showed her the large area of active NVE on the left eye and advised the treatment plan. She later selected PRP with no adjunct anti-VEGF injection as the treatment. Let's have a look at the real workflow, where the patient used their appointment card to scan the barcode and get a small piece of paper that will navigate them through each station, starting from VA, IOP, autorefraction, and brief history taking, followed by pupil dilation if needed, and imaging room throughout exam station. You can see that the flow is quite smooth. We only ask the patient to keep following the signs and color and use their brains as little as possible. On the right side, we kind of exaggerate each commonly used devices from OCT scan and standard 55-degree fundus camera to Optos color fundus photography. It is noted that combining varieties of tests into one screen using pack system can be convenient, but the trade-off is reduced image resolution from compressed files. Okay, finally, let's move to example cases on how we incorporate Optos into multimodality imaging. This patient with recently decreased nasal visual field was referred to us for antiviral treatment because of the diagnosis of presumed acute retinal necrosis. However, Optos color fundus photography showed severe exudative RD in temporal retina, whereas further FA revealed a classic appearance of multiple light bulb macroaneurysms suggestive of a diagnosis of coast-like disease or Leber's miliary aneurysm. So we give this patient an off-label injection of faricimab, hopefully to partly reduce the number of aneurysmal lesion and subsequent laser. Another patient with diabetes who underwent PRP laser in the left eye elsewhere presented with active NVD with apparent insufficiency of PRP laser. Interestingly, subretinal serosanguinous lesion was detected in the peripheral retina in the right side. Past medical history include ischemic stroke that required him to regularly take dual antiplatelet. So we performed Optos FA which further highlight active NVD and large areas of retinal non-perfusion. So PRP addition using conventional single spot laser was performed to avoid overlapping treatment or confluent burn which may lead to visual field defect seen in protocol S study. And the diagnosis on the right side is peripheral exudative hemorrhagic chorioretinopathy, where the name is quite fancy, but this condition is in fact so common that it has its own nickname called pseudomelanoma. And pathogenesis is speculated to resemble PCV due to similar polypoidal lesions seen on ICG angiography but occurred in peripheral retina. Compared with the prior literature, our patient possessed the same ICG findings and risk factors including high-dose antiplatelet therapy, so we performed standard PRP combined with focal chalky white burned laser on the lesion in the left eye. And this patient with PDR both eyes who underwent phaco on the right side and PRP on the left presented with good vision during early post-operative period, so we thought that subsequent PRP laser wasn't necessary and lost the follow-up visit for 2 years. As expected, he came back with a disaster including advanced NVG in the right and thick pre-retinal hemorrhage with TRD in the left. VA was 2100 and hand motion respectively. We were able to save his vision on the left side by PPV but not in the right, despite full PRP and several interventions by glaucoma specialists. So ultra-widefield color fundus photography also pretty beneficial to help assess whether laser retinopathy is adequate. The photo showed that laser seemed to cover the anterior part, but more supplement is needed on the posterior portion. It can also be beneficial in evaluating myopic traction maculopathy after surgery in the long run, since morphology may return to normal during the first few years post-op, but posterior staphyloma can progress and increase risk of recurrent pathology over lifetime. Lastly, there's been a paradigm shift towards minimally invasive RD repair where we can extend pneumatic indication beyond the conventional ones, and the technique is much more simpler that my year 2 resident can now reattach simple RD themselves. For example, we perform pneumatic with LIO on this patient with chronic RD with inferior grade BPVR at post-op day 3. The retina is well attached, but there is some persistent choroidal folds with disrupted outer retinal layers due to its chronicity. 1 week post-operatively, visual acuity improved from hand motion pre-op to 21-25 with a residual inferior subretinal fluid. Finally, I would like everybody to take time and actually watch the current flow of your practice from check-in to check-out, especially on patient's perspective, so that we can make our practice efficient and lean as much as possible. In the end, to determine whether one's practice is successful or not, it ultimately comes down to patient satisfaction, which is a final product of several factors, including not only competent doctor, but also painless procedures, reduced treatment cost, and shortened waiting time, and doctor-patient relationship, of course. All of which could be reinforced by an efficient workflow built by foundation of time, space, and data. Finally, I would like to take this opportunity to advertise the coming event on Saturday, June 24. We'll be having a pneumatic webinar organized by Toronto University. The registration is up there, it's free, and you just scan the QR code if you're interested in. Okay, that is all. Thank you very much for your kind attention.
Thank you, Dr. Yotpong, for that fantastic presentation. And I truly take your note on patient waiting times. You know, especially it was fascinating seeing the time, space, and data analysis. So, you know, thank you, everyone. You know, thank you, Dr. Jacob and Dr. Yotpong, for sharing your fantastic experiences for us. I hope everyone has learned something from it. I have for certain. You know, thank you specifically, Dr. Jacob, for sharing your real-world examples, and thank you, Dr. Yotpong, for putting everything together to show how it all comes together in clinical practice. And, you know, all these things do make a significant contribution towards patient compliance. And as we know, happy patients always equate to good outcomes mostly. So I now open the floor to any further questions from the audience and any contributions from our other panelists.
I think it's really nice for Dr. Yotpong to share on especially your flow and the integration of your system into your flow. I think important during this, I think you probably tighten and crystallize the whole process during the COVID, so that we really don't spend a lot of time, how should I say, patients running through all the different rooms and try to streamline the whole process so that I can catch patient in and out as fast as possible with minimal contact. Yeah, excellent. Yeah.
I think this is particularly the case for patients in private practice where they are willing to pay out of pocket just to minimize their waiting time and spend more time with their physicians to discuss more options, not only about what treatment is suitable for their disease status, but also some non-medical aspects like their lifestyle or their work. So if we can provide that benefits to the patient, and then I think the follow-up adherence will be really good. Thank you.
Yes, I think that is a good point, because we know for sure that especially with diabetic patients, you know, non-compliance is probably one of the most significant contributing factors towards failure of treatment. So if there are no further questions, once again, I thank everyone, all the panelists, Dr. Jacob, Dr. Yotpong. I hope to meet you personally at one of our meetings, and it'd be great to catch up. I need to learn about the slow lane and fast lanes, you know. And if I could just a word to everyone, please remember that we do have a questionnaire right at the end. I can reassure everyone that it's a very short questionnaire at the end of the next video. and it would truly help us with future webinar planning. So thank you. Good night all.
Bye-bye.
Bye.
Unlike conventional fundus cameras, Optos ultra-widefield devices capture high-resolution 200-degree views, showing 82% of the retina in less than half a second. There are many reasons why Optos ultra-widefield imaging is clinically essential for your diabetic eye care. Here, 6 specialists share some of those reasons.
The International Wide Field Imaging Study Group defined nomenclature based on anatomic landmarks to enable doctors to consistently describe ultra-wide field and wide field retinal images. The term ultra-wide field is defined as an image showing the retina anterior to the vortex vein ampulla in all 4 quadrants, whereas wide field images are centered on the fovea and include retina in all 4 quadrants posterior to and including the vortex vein ampulla. Only Optos technology can produce single capture ultra-wide field images as defined by our study group.
The presence of predominantly peripheral lesions on color ultra-wide field images was associated with an almost 5-fold increased risk in diabetic retinopathy progression over 4 years, independent of baseline severity and hemoglobin A1C. Subsequent larger studies have shown the increased risk is best associated with non-perfusion observed using ultra-wide field fluorescein angiography. These findings demonstrate that detailed peripheral retinal evaluations with ultra-wide field fluorescein angiography provide important information that is necessary to completely assess the risk of diabetic retinopathy progression.
Our products use a proprietary imaging system to capture a high-resolution ultra-wide field image of the retina. Our red and green lasers are scanned about a proprietary mirror system, creating a 2-dimensional scan point in space, or our virtual point. The lasers then scan about the whole of the retina, creating this 200 degrees ultra-wide field optomap in under half a second.
We are facing an increasing number of diabetes patients in all Asian countries. Early detection of retinopathy is key. Optos 200-degree ultra-wide field imaging doesn't miss any earlier sign of retinopathy, which we used to miss with a 45-degree conventional fundus camera. It enables us to provide earlier treatment to the patients, and I would say is the best device for the screening of DR.
The beauty of Optos ultra-wide field imaging is that it gives us not only color images, but also autofluorescence and angiography images. This allows us to perform quick screening as well as detailed examinations of lesions such as hemorrhages and non-perfusion areas.
I think one of the biggest advantages here is that without having to take multiple images and montaging them, we're able to get wide field fundus imaging in a non-dilated pupil. This is a huge advantage in our practice where we see a large number of patients walking into our outpatient department.
There are many reasons why Optos ultra-widefield imaging has been well received across the globe. This is supported by more than 2,000 clinical studies. Many practices around the world recognize Optos as the standard of care.